So let's talk a little bit about criteria for ACT. Now, I'm going to talk about the primary criteria for ACT as used in different states currently, and I'll draw some of the distinctions between the original criteria, and also note that there are, of course, special ACT teams addressing particular problems. But the primary criteria have been for people who are difficult to engage in outpatient clinic-oriented services. The primary emphasis and the primary interest in states in implementing ACT, I won't say entirely, but I think a strong driving force, has been the very high cost of inpatient psychiatric treatment, in many places between $500 and $1,000 a day. And so by focusing ACT services on people who are so-called high utilizers of inpatient services, the thinking was that you could provide services in a more cost-effective manner. And so there's been a lot of emphasis in terms of high utilizer populations, which are usually defined as, say, having 2 hospitalizations or, say, 3 hospitalizations over the past year, or having had a prolonged hospitalization, say, more than 3 months over the past year. Along those lines, ACT has been used successfully in deinstitutionalizing or transitioning people from long-term state hospital stays into the community. What's interesting to note is that the original ACT model and the original criteria for ACT services were not focused only on high service utilization. That was one of the foci, but not the only one. The other one was severe impairment in psychosocial functioning, to the extent that people needed ongoing prompting, lots of assistance to get very basic daily living needs met. Interestingly, most states do not have that as a criterion for entry into ACT, which is part of what makes me think that the driving force behind disseminating ACT has been the anticipated cost savings by reducing hospitalizations. That having been said, there's every reason to believe that people with severe psychosocial impairment can benefit from ACT services because it can engage them in rehabilitation and other services that they clearly would not otherwise get. In terms of the core features, like what's provided by ACT services, symptom monitoring and medication management, probably one of the most important services that's provided, and my guess would be it's one of the most important ones in terms of decreasing rehospitalizations and relapses and the like. Providing housing services has increasingly become a major task for ACT. I was meeting with a group of program leaders yesterday, and very similar to experiences that I've seen on the East Coast, the amount of time that's spent by ACT teams helping people secure housing, maintain housing, dealing with housing issues is really a huge amount of time. And in fact, there was some discussion about, and I believe that a person had actually been hired as a housing specialist because they was consuming so many of the clinical resources addressing just basic housing issues. So it's a very important topic. Healthcare, there's increasing recognition of the poor health, the fact that people with severe mental illness die on average more than 2 decades earlier than people who don't have it, largely due to health conditions, and largely due to health conditions that are related to sedentary lifestyles, poor health care self-management. There is some evidence that people don't receive as good health care as well. But there's a great interest, and there needs to be, in terms of improving the quality of health with people with severe mental illness. Practical assistance in terms of getting basic needs met, whether it's food-based needs, legal, medical, those kind of things. Coordination with families. So these are core functions of ACT, although there are many other functions that they may or may not serve, depending on the nature of the team and the skills and expertise of the providers. It's also just worth mentioning briefly, because people have heard about it, there may be examples of it, intensive case management. And intensive case management is a model that is similar to the ACT model in many ways, with the primary difference being that you don't have a formal sharing of caseloads. You tend to have similar ratios or intensity of services, 1 to 10, and the expectation that the majority of services are provided in the community, a range of different services are provided, 24-hour coverage and the like, but you don't have the shared caseloads, the actual configuration of the intensive case management teams themselves is not as well articulated, and there is less research on the intensive case management model. So, let me get into talking a little bit about the current status of ACT as an evidence-based practice. Let me just talk, what do we mean when we say evidence-based practice? I mean, in a nutshell, the term evidence-based practice refers to an intervention. Let's just talk about an intervention in psychiatry for mental illness, but an intervention that's targeting an important outcome of some sort. It could be the symptom of the psychiatric illness. It could be an area of functioning known to be impaired. An intervention that targets a particular outcome is standardized in some form, like a manual, and has been shown in controlled research, multiple trials of controlled research by at least 2 different investigator teams to improve outcomes. So we're basically talking about standardized interventions known to improve outcomes. That's what we call evidence-based practice. So ACT, as of 10 years ago, was really already considered an evidence-based practice because of the research that I will be reviewing. And just examples of that, in the original PORT stands for Patient Outcomes Recommendations for Treatment. These are they develop special PORT panels of experts to make specific recommendations for the treatment of a wide range of diseases. And so the first PORT came out with its recommendations for the treatment of schizophrenia in 1998, and ACT was already one of the services that was recommended. NAMI has had an initiative to make ACT available in all of the different states. Over 10 years ago, President Clinton asked the Healthcare Finance Administration to make PACT reimbursable, and so on and so forth. There's lots of people have accepted the fact that ACT, in fact, is an evidence-based practice. But so let's get into talking about, well, what is the evidence? What's an evidence-based practice for doing? What are the reasonable expectations of ACT? And then for people who want to know just in terms of the reviews, there are many reviews of the ACT research literature. This is just a sampling of them. Interestingly, the vast majority of the research on ACT was conducted between about 1980 and about 1995. There is additional research going on evaluating ACT, but it's usually examining particular applications of ACT to special problems, like a criminal justice population or a homeless population or something like that. The majority of studies on ACT focusing on the kind of a revolving door type patient, supposedly, were done from the 80s to the 90s. And one of the things that it probably means is that because of the impact of ACT on decreasing lengthy hospital stays that were typical in the 1980s, the anticipated cost savings of ACT, which was based on expectations of many days in the hospital, have probably been narrowed or decreased somewhat, because nowadays most psychiatric hospitalizations are much briefer. I understand in San Diego, 3 to 5 days. And so I think that there's probably a need to justify and to look at ACT as an intervention or as a way of organizing services for reasons above and beyond just saving money and preventing hospitalizations. But we can get into that in a little bit later. So let's get into what are the studies on ACT. What does the controlled research tell us that ACT does and doesn't do? So there are 30, probably a little bit more at this point, but by my last count, about 30 randomized controlled trials of ACT. Most of these studies have been done in the U.S. Most have been done in urban settings. There are replications of ACT that have been done abroad, and there's also failures to replicate ACT abroad. And while some of those failures are controversial, I think it's important to look at ACT as a remedy for a particular problem within a particular mental health system. If the mental health system is a clinical-oriented system and nobody ever goes out and sees people in the community, then ACT becomes a solution to that as a problem. If you have a mental health system in which people routinely go out and see sometimes people in the community if they don't come in, then you may not need ACT properly, or you may not need the exact same configuration of ACT. And that, my belief, is that that's one of the reasons why attempts to replicate ACT in London have been unsuccessful, whereas they have been successful in certain other places like Australia. So most of the studies have included people with schizophrenia, spectrum disorders, or are focused on that population, although it's thought to be appropriate for the broad range of people with severe mental illness. Average follow-up is about 18 months across these studies. So these are pretty good studies. And then this is a summary. I like to take kind of the simple man's approach to summarizing research studies, unless I can't get away with it, or I'm working with somebody who loves meta-analysis. And so this is a very simple way, and what we did simply was to take every different outcome that was of some interest, and we looked at the number of studies that found a positive effect of ACT on that outcome, and the number of studies that didn't find a positive effect on that outcome.